May now request Dr. Bhavani ma'am of GMC Srikakulam to go ahead with the presentation. I request Dr. Satish Shah,
Yeah, Praveen.
Head of the Department, Government Medical College, Paderu, to moderate this session. Thank you.
Welcome, Bhavani.
Sir.
Please go.
Sir. Good evening, sir. Good evening, dear respected seniors and dear colleagues. Today, first I am talking regarding lumen tubes. Here I'm going in these headings. And coming to the indications of lumen tubes, we have absolute and relative indications. Absolute indications include to avoid spilling or contamination of the normal lung in case of pulmonary hemorrhage, lung abscess or infected cysts. Differential ventilation required in case of bronchopulmonary fistulas, bronchopleural cutaneous fistula, large unilateral bulla, bronchial trauma, severe unilateral lung contusion, lung lavages, and surgical indications like video-assisted thoracoscopic surgery, robotic-assisted thoracoscopic surgery, and robotic-assisted minimally invasive cardiac surgeries, and high priority surgical exposures in thoracic aortic aneurysms, pneumonectomy, upper lobectomy, mediastinal exposures in thoracoscopies, and also in low priority surgical exposures in middle and lower lobectomies, subsequent resections, esophageal surgeries, and so on. Coming to the methods of lung separation, we have double lumen tubes, bronchial blockers, and endobronchial tube. In the double lumen tube, we have, as the name is indicating, it is having two lumens, tracheal lumen and bronchial lumen. In a bronchial blocker, after placing single lumen tube, a bronchial blocker can be placed to isolate the lung, and endobronchial tubes, they will be inserted into the concerned bronchus. Coming to the history, Ednard Flusser and Claude Bernard, they are the physicists who designed a simple catheter to sample gas from isolated areas of dog's lung, followed by Wolfberg in 1871, who created an endobronchial single lumen tube. Later, Loewy and von Schlotter in 1905 conducted experiments on human volunteers using Fick's principle and Bohr's equation. In 1932, Gale and Waters, they molded a rubber endotracheal tube by heating it in hot water and formed a right or left-sided tube, and they inserted blindly under a deep spontaneously breathing anesthesia, and this carinal cuff at the carina is helpful as an airtight seal for intubated bronchus and also occluded the opposite bronchus. When one lung ventilation is required, they just withdraw it backwards, and after one lung ventilation, for two lung ventilation, they pull back the tube and two lung ventilation was restored. Rovenstein 1936, they introduced endobronchial tubes from woven silk, where they have tracheal and bronchial cuffs, and lack of suctioning is a problem in this. Megali in 1936 introduced cuffed endobronchial tubes in attempt to compensate for different anatomy of the main stem bronchus. Here, he introduced left and right side bronchial tubes. In left tube, inflatable balloon was there for occluding the left main bronchus. For right side, a distal wire spiral was present to permit to ventilate the right upper lobe bronchus. And Eric Carlens in 1950 introduced the double lumen tube for separation of the lung. Here, it had two lumens, tracheal lumen and bronchial lumen, and they are shaped anatomically to pass mainly into the left main bronchus. It had a carinal hook. Above the carinal hook is the tracheal cuff. This is the tracheal lumen, and this is the bronchial cuff, and this is the bronchial lumen. This is the Carlens left-sided tube where tracheal lumen is present above the carina, bronchial lumen into the left main bronchus, and this is the carinal hook at the level of carina. Roger Bryce Smith in 1959, he removed the carinal hook, and this is also a left-sided double lumen tube having two cups. Here, the lumens are placed anteriorly and posteriorly instead of side by side. Tracheal tube is placed anteriorly and bronchial lumen is present posteriorly. Advantage is, because of its leak, it caused less vocal cord trauma on insertion. Tracheal opening, as it is anterior, it sat over the anterior carina rather than the right main bronchus, but suctioning was difficult with this type. Then Frank Robert Shaw, 1962, he tried to overcome the shortcomings of Carlin's tube regarding its anatomical structure, its cost, lumen, requiring small suction catheters, and hooks is sometimes caught in the bronchial sutures, requiring reopening of the chest. So, what the changes he tried to bring are slotted endobronchial tube and incorporation of pilot tubes for cuff inflation, and two semicircular D-shaped lumens are placed side by side. New rubber compound was introduced and color coding for the cuffs. Bronchial lumen showed blue color. Right and left side tubes and large bore making suction more possible. This is a double lumen tube Robert Shaw's. Here it had tracheal lumen, and by the side of it is the bronchial lumen. The tip of the tracheal lumen ended proximally. This is the tracheal cuff. Bronchial lumen continued little bit distally more, and this is the bronchial cuff. This is color coded. So the two pilot balloons, white one is for tracheal and blue is for the bronchial pilot balloon. Before going to the other part, first a small review regarding the anatomy of tracheobronchial tree. Trachea divides into right and left bronchi, and within 2.5 centimeters from the carina, right main bronchus gives branch to the right upper lobe bronchus, which divides into apical, anterior, and posterior segment. Whereas whereas from the carina, left main bronchus divides into left upper lobe and left lower lobe bronchus after 5 centimeters from the carina. As right upper lobe bronchus is dividing very early, that is just 2.5 centimeters from the carina, there is definite requirement for ventilating the right upper lobe bronchus. So these are the differences between the left and right double lumen tubes. In the right tube, the shape of the cuff is different, and also there is a small slit opening for ventilating the right upper lobe bronchus. Indications for a right side double lumen tube are any contraindication to placement of left side double lumen tube, distorted anatomy of the entrance of left main stem bronchus, compression of the entrance of the left main stem bronchus, left lung transplantation, left side sleeve resection, and left side pneumonectomy. Because of the bronchial anatomy, the left side double lumen tube is simpler to use and has a greater margin of safety than right-sided one. And there is also more failure chances in the right side double lumen tube is used. Failure chances to ventilate the right upper lobe in 11% of the patients, and obstruction of the right upper bronchus in 89% of patients after right double lumen tube is placed. So in Mallinckrodt, they introduced the opening slot of the ventilating orifice of the right upper bronchus has been widened, and a contraindication for right side DLT use is the presence of anomalous right upper lobe takeoff from the trachea. Here, these are the various sizes of double lumen tube and various ages. For about 8 to 10 years, 26 French gauze is used, and 10 to 12, 26 to 28 French, 12 to 14 years, 32, 14 to 16 years, 35, 16 to 18 years, 35, and adult female 35 to 37, adult male 39 to 41 size are the usual sizes. And depending on the width of the trachea in X-ray in millimeters, we can also assess the size of the double lumen tube. At the level of clavicles, this white arrow represents the level of clavicle, and this black line is width of the trachea in millimeters. Depending on the tracheal width in millimeters, if it is more than or equal to 18, left side double lumen tube of 41 French, and depending on the width of the trachea, size will be measured. And this is the different size of flexible fiber optic bronchoscopes with various sizes of double lumen tubes and the size of the flexible fiber optic bronchoscopes. Depth of insertion. It is determined by appropriate bronchial cuff position, which is confirmed by bronchoscopy. Correlation between patient's size and placement of depth. If the patient's height is 170 centimeters, depth of insertion is 29 centimeters at the angle of mouth, and for every 10 centimeters difference in height, depth varies by plus or minus 1 centimeters. Left double lumen tube depth is 12 plus 0.1 into height in centimeters. Average lip measurement is 29 plus or minus 2 centimeters. However, this relationship is not always not strong enough. Advantages are this is the best device for absolute lung isolation. It is quickest to place successfully. It can be converted back and forth from one lung ventilation to two lung ventilation. Because of its large lumen, suctioning of both lungs can be done individually, can be placed without a fiber optic bronchoscope. CPAP to non-dependent lung and PEEP to dependent lung can be done, and bronchoscopy to isolated lung can be done. Disadvantages are limited available sizes, difficulties in selecting the size, difficult to place during the laryngoscopy, major tracheobronchial injuries, intraoperative displacements. It is not ideal for postoperative ventilation and must be changed for a regular single lumen tube for postoperative ventilation. Coming to the preparation, first we should inflate the tracheal and bronchial cuffs to check for leaks. Consider adding water-soluble lubricant to the stellate and insert the stellate into the bronchial side, ensuring that the stellate is not protruding out of the tube. The connector which connects the double lumen tube to the ventilator circuit should be assembled and it should be ready before intubation. A fiber optic bronchoscope should be available to confirm the position of the double lumen tube. Coming to the techniques of insertion, we have blind insertion technique or fiber optic guided placement. Blind insertion technique, first we perform direct laryngoscopy and visualize the cords. After visualization of the cords is important as these are large and placement is more challenging than placement of a single lumen tube. Once the cords are visualized, gently advance the double lumen tube with the tip of the bronchial curve concavity facing anteriorly through the cords until the bronchial cuff passes through the cords. Then the tube is to be turned 90 degrees to the side which it is supposed to pass. If it is left side tube, we turn it to left side 90 degrees, or if it is right side tube, we turn to right side 90 degrees, and then it is advanced till resistance is felt. Average depth is 29 plus or minus 2 centimeters. Using a fiber optic bronchoscope, we pass the fiber optic bronchoscope through the bronchial lumen and guide the double lumen tube over the fiber optic bronchoscope, increase the accuracy of placement. Methods to confirm the position of the double lumen tube. It can be either by auscultation, fiber optic bronchoscopy, chest X-ray, compartment capnography, or surgeon. Checking the position of a left double lumen tube. First, after the double lumen tube is placed, we inflate only the tracheal cuff without inflating the bronchial cuff, and we ventilate. When ventilating, the air passes through the tracheal and bronchial lumens, and hence we hear entry of air in both sides, right and left side, on auscultation. If it is not, just withdraw 2 to 3 centimeters and repeat. Now we inflate the bronchial cuff with about 2 to 3 ml of air and clamp the tracheal lumen. Then we check for breath sounds. When we inflate, as the tracheal lumen is clamped, air doesn't enter into the tracheal lumen. So as it enters only into the bronchial lumen, if it is a left side tube, we should hear only on the left side with absent air entry on the right side. For checking the right side, clamp the bronchial lumen and inflate. Now, as the bronchial lumen is also inflated, when we ventilate, as the bronchial lumen is clamped, air enters only through the tracheal lumen and the right side air entry can be heard. Checking by fiber optic bronchoscope, during a bronchoscopy, when we see at the level of trachea, carina, we see the bifurcation of right and left. Then as the scope is advanced into the right side, the first thing to confirm it is right bronchus is separation of the right upper lobe bronchus, and as the fiber optic bronchoscope is advanced, we should see the division of right upper lobe bronchus into apical, anterior and posterior, which is the confirmation for right-sided bronchoscopy. Now, in a left double lumen tube, when we pass the fiber optic bronchoscope through the tracheal lumen, what we see is right bronchus and tight sealing of the cuff of the left main bronchus. As the tube is advanced, what we see is separation of the right upper lobe bronchus and its division into apical, anterior and posterior. Then when we pass the tube through the bronchial lumen, we should see the division of left upper lobe bronchus into left main bronchus into left upper lobe and left lower lobe bronchi. And in case of right double lumen tube, what we see is separation of the right upper lobe bronchus and its division into apical, anterior, posterior parts should be seen. This is the optimal position of right and left double lumen tubes in X-rays. This is the right side and this is the left side. Coming to the testing for adequacy of sealing, we have Benioff's air bubble test with catheter underwater assembly, Whistle test and capnography. This is Benioff's air bubble test. Here, this is a left-sided double lumen tube, tracheal cuff and bronchial cuff, both are inflated. What we do is we place a suction catheter. One end will be connected to the suction port of the tracheal lumen and the other into the underwater seal. And we clamp the tracheal lumen. When we inflate the reservoir bag, the air passes into the left side only. If there is adequate sealing, no air escapes back and no air bubble will be seen. If the cuff is not sealed, bronchial cuff is not sealed properly, the air comes back through the tracheal lumen and we see the air bubbles in the underwater seal. This indicates inadequacy of sealing of the bronchial cuff. In Whistle test, what we do is instead of keeping the other end of the suction catheter in the underwater seal, we add a whistle. We connect it to a whistle. Here, this is the whistle. One is at the tracheal suction port, one will be at the whistle. When the air escapes, comes back through the tracheal lumen, because of the PEEP, it makes the whistle sound, which indicates the inadequacy of cuff sealing of the bronchial cuff. This is capnography. Here, the tracheal lumen is clamped and a capnograph is connected to it. And if the cuff is properly sealed, no air will be escaping and there will be flat line on EtCO2. Whereas if there is inadequacy of cuff sealing, the air will be escaping back into the tracheal lumen and we can see tracings of EtCO2 in a capnogram. Troubleshooting are common issues are difficulty with insertion, impaction at the glottis or cricoid, wrong bronchus placement and displacement. Solutions are using a fiber optic bronchoscope, stillet or bougie, and we can maintain the position of the head. Gently rotate the tube towards the target bronchus and the patient's head to be rotated to the opposite side to assist with insertion. Complications are failure to intubate, malpositioning, tracheobronchial tree disruption, tracheal laryngitis, collapse of the right upper lobe when right double lumen tube is used, inadvertent stapling of the endobronchial lumen in the bronchus, injury to the lips, tongue, and airway mucosa. Absolute contraindications are difficult airway. Because of its large size and complexity, double lumen tube make placement more challenging and increase the risk of airway trauma, airway lesions or tumor, pre-existing tracheal stoma or stenosis, distorted airway anatomy. Relative contraindications include limited mouth opening, small patients, aberrant takeoff of the right upper lobe bronchus, and descending thoracic aortic aneurysms. And need for lateral reintubation. If there is any requirement of postoperative ventilation, double lumen tube should be taken off and single lumen tube should be reintubated. And come to recent advances, newer one is Fuji system, silobronchial left DLT, where the short and wire reinforced endobronchial tip is present to avoid kinking. In Kleine right DLT, there is a long oblique bronchial cuff with 2 slots for right upper lobe. It is made of silicone, making it more resistant to tearing on teeth. The other one is Papworth Bivent tube, where it has an inbuilt bronchial blocker and it has single inflatable high pressure low volume tracheal cuff. Distally, there are 2 pliable crescent shaped flanges which form a fork tip, and we can pass the bronchial blocker in whatever direction we require. The other thing is Viva site blocker, where there is a camera at the tip of the double lumen tube, where after connecting to a monitor, we can visualize it directly. Thank you. The next topic is torsade depointis. Next topic is torsade depointis. Here, torsade depointis, it is a French word which means twisting of the peaks. It is a specific type of abnormal heart rhythm that can lead to sudden cardiac death. It is a polymorphic ventricular tachycardia that exhibits distinct characteristics on the ECG. It was described by French physician Francois Desertin in 1966. It is prolongation of the QT interval can increase a person's risk to develop this abnormal heart rhythm, and occurs in between 1% to 10% of patients who receive QT prolonging antiarrhythmic drugs. Signs and symptoms. Most patients will revert spontaneously to normal sinus rhythm. Symptoms include palpitations, dizziness, lightheadedness, and fainting, and even sudden cardiac deaths may also occur. Etiology, it can be either inherited or acquired. Common causes include drug-induced QT prolongation. Less often, diarrhea, low serum magnesium and low serum potassium, or congenital long QT syndrome can be seen. In malnourished individuals and in chronic alcoholics, due to deficiency of potassium and or magnesium, QT prolongation can occur and torsade depointis may be seen. Certain drugs and combinations of drugs resulting in drug interactions are common contributors to torsade depointis. QT prolonging medications such as clarithromycin, levofloxacin, or haloperidol taken concurrently with cytochrome P450 inhibitors such as fluoxetine, cimetidine, or particular foods like grapefruit can also result in higher than normal level medications and can prolong QT interval in the bloodstream. A torsade depointis cardiac event precipitated by loperamide has also been reported, but the dose is well beyond the therapeutic range. Risk factors include medications, hypokalemia, hypomagnesemia, hypocalcemia, bradycardia, heart failure, left ventricular hypertrophy, hypothermia, subarachnoid hemorrhage, and hypothyroidism. Before going to the pathophysiology, first let us discuss small thing about the normal action potential in a cardiac muscle. Here, the resting membrane potential is minus 90 millivolts. When we plot a graph with membrane potential on y-axis and time on x-axis, resting membrane potential is minus 90 millivolts, and when an action potential comes, sodium, it is a positive ion mainly present in the extracellular compartment. It will be, because of opening of the sodium channel, this sodium enters into the cell, raising the membrane potential from minus 90 millivolts to more positive side. It is followed by opening of the potassium channels and pushing of potassium from the cell outside the cell, resulting in a small drop in the resting membrane potential. In phase 2, there will be opening of the calcium channels. Potassium channels will be still open, where potassium will be coming out of the cell from inside, and calcium will be coming from outside to the inside the cell. As both positive ions are moving in opposite directions, the resting membrane potential will be in a plateau phase. This plateau phase is because of opening of the calcium channels. Then comes phase 3, where the calcium channels close and slow gated potassium channels will be open, and potassium comes out from the cell, resulting in again decline in the resting membrane potential. Phase 0 is opening of sodium channels, raising the membrane potential. Phase 1, small decline in resting membrane potential because of opening of potassium channels. Phase 2 is the plateau phase, calcium channels opening, and phase 3 is closing of calcium and continuous opening of the potassium channels. These are the main phases. This is phase of depolarization, and this is the phase of repolarization. So for the phase of repolarization, potassium is the main ion here. The main reason for torsade depointis is either early after depolarizations or transmural re-entry. Repolarization of cardiac myocytes occur in phases 1, 2, and 3, predominantly by the outward movement of the potassium ions. In torsade depointis, however, repolarization is prolonged. This can be due to electrolyte imbalances like in hypokalemia, hypomagnesemia, hypocalcemia, because of bradycardia, certain drugs like disopyramide, sotalol, amiodarone, amitriptyline, chlorpromazine, erythromycin, and congenital syndromes. The prolongation of repolarization may result in subsequent activation of an inward depolarization current, which is known as early after depolarization, which may promote the triggered activity. The second is transmural re-entry. Here, this is a cardiac muscle. We have epicardium, myocardium, and endocardium. These are 3 layers. And re-entry due to dispersion of refractive petals is also possible because of the M cells, which are found in the mid-myocardial layer. They show a more prolonged repolarization phase in response to potassium blockage than other cells. In turn, this produces a zone of functional refractoriness in the mid-myocardial layer. Here, this is the time for repolarization. So, M cells in the myocardial layer show prolonged duration of repolarization when compared to the cells in epicardium and endocardium. Now, when a new action potential is generated, the mid-myocardial layer will remain in refractory period, but the surrounding tissue will be depolarizing. As soon as the mid-myocardial layer is no longer in refractory period, excitation from the nearby tissue will cause a retrograde current and a re-entry circuit that will result in a positive chronotropic cycle, and this may lead to tachycardia. Here, myocardium, because of prolonged repolarization phase, it will be in the refractory period, and sometimes stimulus in the endocardium may create a re-entry circuit. Clinical features include ECG tracing in torsades demonstrates a polymorphic ventricular tachycardia where there will be twisting of the QRS complexes around the isoelectric baseline. It is hemodynamically unstable and causes a sudden drop in arterial blood pressure leading to dizziness and fainting. Depending on their cause, most individual episodes of torsade depointis revert to normal sinus rhythm within a few seconds. Some may also persist and possibly degenerate to ventricular fibrillation, leading to sudden death in the absence of prompt medical intervention. Torsade depointis is mainly associated with prolonged QT interval. QT interval is starting from the Q wave to the ending of the T wave. Long QT intervals predispose the patient to R-on-T phenomenon. R means ventricular depolarization. It occurs during the relative refractive period at the end of depolarization, that is the latter half of T wave. And RRT can also initiate torsade depointis. Rate collected QT interval is, it is a measure of the time for the heart's ventricle to repolarize after each beat, adjusted for the heart rate. Since the QT interval naturally shortens at higher rates, correcting for heart rate is necessary to accurately assess heart rhythm and identify potential abnormalities, as a prolonged QTC indicate a risk for certain arrhythmias. Here, corrected QT interval can be calculated by QT by square root of RR. Average QTCE for a general population is 380 to 400 milliseconds. How will we diagnose this? First, measure QT interval, correct heart rate if it is above 60 beats per minute, determine QTC interval and check if it is greater than 500 milliseconds. Compare QTC to previous QTCs to determine if it is lengthening, and QTC for men is 440 milliseconds and for females it is 460 milliseconds. Management, acute cases, remove the offending drug and correct potassium and magnesium levels. Magnesium is a drug here, and as it suppresses the early after depolarizations which cause torsade depointis, it works by decreasing the influx of calcium into cardiac cells and lowers the amplitude of early after depolarizations. It is given a dose of 1 to 2 grams intravenously in 30 to 60 seconds and repeated for 5 to 15 minutes if required. Potassium is the second drug of choice as it increases the repolarization. As it causes rapid repolarization. Lidocaine is sometimes the initial medication used during an emergency due to its effectiveness in treating ventricular arrhythmias. Its mechanism is believed to shorten the QT interval, which can be helpful for torsade depointes caused by certain drugs. Isoproterenol is used as a part of the initial treatment for torsade depointes, where bradycardia is the contributing factor to the arrhythmia. Isoproterenol is a non-selective beta-adrenergic agonist. It increases the heart rate, which helps to shorten the QT interval in the refractory period. This shortening effect can help prevent the pause-dependent events. Contraindication: this isoproterenol is congenital. In long QT syndromes, isoproterenol is contraindicated, where it may paradoxically lengthen the QT interval and worsens the condition. Temporary venous pacing, especially atrial pacing, for 90 to 100 beats per minute until QT interval is normal, and defibrillation is required. The patient is in VF, VT, or cardiac arrest, and after recovery from VF post cardiac arrest, implantable cardioverter defibrillator can be used along with the beta blockers, and congenital long QT syndrome can be treated with beta blockers and 9CD. Thank you.
Thank you, Bhavani.
Thank you, sir.
Very nicely explained about the both. History is very nice actually.
Thank you,
Regarding
sir.
double tubes, I
Thank
think
you,
it is
sir.
very useful for the postgraduates. Any questions from the? Praveen?
Okay. Sir, anything you want to add, please ask.
Basically, most common question in exams is which side the double lumen tube. This is the most common question. So basically, if you place the DLT, the tip of the DLT in the flat position, the tip, other side, the tip is going towards left, it is the left side. It is towards right, it is the right side. Another thing is regarding cuff inflation also. Bronchial cuff, it should be 2 to 3 ml, and the tracheal cuff should be around 5 to 8 ml, like that. And you nicely explained the cuff leaks, but
Yes.
they should know about the volumes also. But the most
Yes.
common mistake, generally bronchial cuff, they inflate with like a legal tracheal cuffs.
Yes.
That is the one thing. And rest of things are very well explained.
Thank
And
you.
most common problem in the insertion is they can place two cuffs in the same side. This is the one of they can go D, 2D, or both in the trachea. This is the most commonest thing actually.
Yes, sir.
So by practical problem is generally what they will do is, suppose left side, they will keep both bronchial and tracheal cuff in the left side only.
Yes, sir.
Then you will complete half of the opposite side. Sometimes both the cuffs in the trachea also. This is what commonest thing happened in a practical experience.
Yes.
By sequential clamping and declamping, you can isolate lungs and you can check the correct positioning in place. Ideal gold standard is anyhow fiber optic. That is the gold standard thing.
Yes, sir. Yes.
Regarding torsade depontis, polymorphic BT, they should differentiate between the BT and torsade. That is very important. That is very important actually.
Yes, sir.
They should clearly understand the pattern, and also they should sometimes they may confuse the VF also. Once ventricular fibrillation comes, patient is almost cardiac arrest patient.
Defibrillation.
Torsade depontis patient doesn't have. He may go into cardiac arrest, but he had symptoms, but he is not a cardiac arrest patient. That they should know. That is the one thing they should know. Another thing is they can you pacing you told, but the thing is that is overdrive pacing they will do. Suppose the heart rate is around 100 or 110, they can go up to 140. They can increase the pacing rate. Once they pacemaker control the heart rate, and slowly they will come down to the around 70. By gradually they will come down the heart rate.
Yes,
that is called overdrive pacing. That is the one of the thing. If everything is fails, then they can do it.
Yes, sir.
And the thing is in torsade depontis, everybody is shocked if the magnesium fails. What is the next drug? Isoproterenol is the drug, because isoproterenol will increase the heart rate. How can the torsade depontis will decrease the isoproterenol is useful in? Because by increasing the heart rate, it decreases the QT interval.
QT interval will be shortened.
QT interval will be shortened.
Yes,
That's
sir.
how that will act. Except for the congenital QT prolongation, rest of the things it is very useful.
Yes, sir.
That I think most of the pieces doesn't know. Only they will say magnesium. But the next alternative is if the magnesium doesn't work, that is the isoproterenol.
Yes, sir.
Okay. Thank you.
Thank you, sir. Thank you.
Sir,
Thank you, sir.
one more point. Only pediatric fiber optic bronchoscope is possible to confirm the position of DLT. Adult bronchoscope will not.
Yeah, yes, sir. Yes, sir, that is true. The adult cannot pass into the DLT, sir, because the cuffs, the inside lumen is
Lumen,
narrow, sir.
lumens are narrow.
Yes, sir. Yes, sir. That is true.